You know how a bad bout of pneumonia can leave you gasping for air, your lungs feeling like they're just full?
Yeah, absolutely. Or maybe you've heard of sepsis, that really scary whole body infection.
Exactly. Well, have you ever stopped to think what happens when the body's own response, its defense against something nasty in your lungs, just goes completely haywire? Like totally off the rails.
It's fascinating, isn't it? How something designed to protect us can sometimes become the biggest problem itself.
Right. Welcome, everyone, to the deep dive. Today, we're getting into something called Acute Respiratory Distress Syndrome, ARDS for short.
Hmm.
Forget the heavy medical jargon for a sec. Just picture this. It's like this massive crisis hitting your lungs. Suddenly, they're under attack from, well, everywhere inside.
And it's critical. It's a situation where the lungs, the organs bringing in the oxygen you need to live, are facing this huge, widespread assault.
So our mission today is to cut through that complexity. We want to get to the core of what ARDS actually is, what kicks it off, and why is it such a serious, serious concern for doctors?
We've got some pretty detailed medical source material here.
We do, and we're going to unpack it together piece by piece so you get a really clear picture of this, well, this really challenging condition.
So maybe the first step is, how do doctors even define this? What is ARDS officially?
Okay, yeah. Fundamentally, it's acute respiratory failure, meaning your lungs suddenly stop working properly.
Right. The oxygen exchange breaks down.
Exactly. And you get this widespread fluid buildup deep inside both lungs. Doctors see it on chest x-rays as these hazy patches.
Bilateral infiltrates.
Right. But here's the key thing. It's not caused by heart failure directly or just by having too much fluid in your body overall. That's a crucial distinction.
That really is key. ARDS is specifically driven by an overwhelming inflammatory reaction right in the lungs.
Think about the lung structure. Tiny little air sacs, the alveoli, right?
Yeah.
And tiny blood vessels wrapped around them.
The capillary.
Yes. In ARDS, something triggers this massive internal inflammatory response that's like setting off fireworks inside. And the inflammation damages those delicate air sacs and blood vessels.
And there's actually a formal definition, the Berlin definition, that helps classify how severe it is.
Right. I was just about to ask about that. How do they measure severity?
They look mainly at how bad the oxygenation problem is. They use a specific ratio comparing the oxygen in the blood to the amount of oxygen being given.
The PO to AO2 ratio.
Exactly that. And they also consider the level of ventilator support needed, specifically something called PEEP, positive end expiratory pressure.
Okay.
So based on that ratio, there are specific ranges, and meeting a certain minimum level of PEEP, they classify it. Mild is a ratio between 200 and 300. Moderate is 100 to 200.
Okay, getting worse.
And severe is anything below 100. All of these require at least 5 centimeter H2O of PEEP.
So those numbers give doctors a quick snapshot. Like, how bad is it? How much help do the lungs need right now?
Precisely.
Yeah.
It standardizes things,
Yeah.
helps with communication, tracking progress, or lack of it.
Okay, that makes sense. So we know what it is, broadly, but what's actually going on inside the lungs? You mentioned inflammation, but talk us through that cascade of damage.
Right. It usually starts with some kind of initial hit, an insult.
Yeah.
Could be directly to the lungs, think severe pneumonia, for example.
Okay.
Or it could be something happening elsewhere in the body, like severe sepsis, a body-wide infection.
Wow, so it doesn't even have to start in the lungs.
Not necessarily, but wherever it starts, this trigger mobilizes a whole army of immune cells within the lung's tiny blood vessels.
Which cells are we talking about?
Mostly neutrophils, but also monocytes, platelets. They all rush in and accumulate there.
Sounds like a traffic jam in those tiny vessels.
It can be, but the bigger issue is that these activated cells start releasing a flood of potent inflammatory chemicals.
Okay.
And these chemicals make the walls of those tiny blood vessels incredibly leaky, much leakier than they should be.
Like the plumbing starts to fail?
That's a good way to put it. This leakiness lets protein-rich fluid and even the inflammatory cells themselves ooze out of the vessels.
Where do they go?
Into the lung tissue itself, the interstitium, and crucially, into the air sacs, the alveoli. They start to fill up with this inflammatory soup.
Not good.
Not good at all. And at the same time, those inflammatory chemicals are directly attacking and injuring the cells lining the alveoli, both types, type I and type 2.
Okay, remind us what those cells do again. Why is damaging them so bad?
Type I cells are the super thin ones. They form the main surface for gas exchange, oxygen in, CO2 out.
Right.
Type 2 cells are really important too. They actually repair the lining if it gets damaged. But their other big job is producing surfactant.
Surfactant, I remember that. It's like a detergent. It reduces surface tension so the little sacs don't collapse when you breathe out.
Exactly, like keeping a tiny bubble inflated. So when type 2 cells get damaged, surfactant production plummets.
Ah.
Now you've got fluid flooding the air sacs
Mm.
and not enough surfactant to keep them open, so they collapse.
Yeah.
Say atelectasis.
Okay, so fluid and collapse. Double whammy.
Precisely. And all of this fluid barrier, the collapsed sacs, leads to severe hypoxemia, dangerously low oxygen in the blood.
Makes sense.
And one more thing, a real hallmark of ARDS under the microscope is the formation of hyaline membranes.
Hyaline membranes, what are those?
Imagine the inside surfaces of those damaged alveoli getting coated with this thick, pink, glassy layer made of proteins and dead cells. It's like wallpapering over the area where oxygen needs to cross. Makes gas exchange even harder.
Wow. It really is a cascade. One thing leads to another, and it just gets worse and worse.
It absolutely is, and it doesn't stop there, unfortunately. The low oxygen levels in the lung tissue can cause the small pulmonary arteries to constrict.
Narrowing the pikes.
Right. Plus, you can get tiny blood clots, microthrombi, forming in those small vessels. And the body releases other substances that cause constriction, too. All this together raises the pressure in the lungs' arteries. That's pulmonary hypertension.
And that puts a huge strain on the heart, right? Especially the right side.
Exactly. The right ventricle has to pump much harder against that resistance. If it goes on long enough or is severe enough, it can lead to right-sided heart failure.
Jeez. And what happens later if someone survives the initial onslaught?
Well, the body does try to repair things. Those type 2 cells start to multiply to try and reline the alveoli. But often, this repair process goes wrong. You get inflammation persisting in the lung tissue, and fibrosis starts to develop.
Scar tissue in the lungs.
Yes, scarring, which can lead to long-term breathing problems and stiffness in the lungs.
So even getting through ARDS doesn't mean you're completely out of the woods.
No, unfortunately, long-term consequences are a very real concern.
Okay, we understand the damage. But let's go back to the beginning. What causes ARDS? What are the main triggers?
We can sort of put them into two main buckets. First, things that directly injure the lungs' primary pulmonary causes.
Okay.
And second, things that start elsewhere in the body but end up affecting the lungs' non-pulmonary causes.
Gotcha. Let's start with the direct lung injuries. What are some examples?
Well, aspiration is a big one. Inhaling stomach contents or other foreign stuff into the lungs, that causes aspiration pneumonia.
Right, nasty stuff.
Yeah. Then there's other types of severe pneumonia, bacterial or viral, direct trauma to the chest causing lung bruising. That's pulmonary contusion.
Like in a car accident.
Exactly. Near drowning is another, inhaling toxic fumes or smoke. And there's also a rarer form, idiopathic ARDS, where we don't always find a clear trigger, but it can sometimes be linked to other underlying lung diseases.
Okay, so direct hits. What about the non-pulmonary causes, the problems starting elsewhere?
Sepsis is probably the most common non-pulmonary cause, that overwhelming body-wide infection and inflammation.
Makes sense given the inflammatory nature of ARDS.
Right. Also something called SIRS, systemic inflammatory response syndrome. It's similar to sepsis, a widespread inflammation state, but maybe without confirmed infection yet.
Okay.
Severe trauma anywhere in the body, even without direct chest injury, can trigger it. Major shock. Pancreatitis inflammation of the pancreas is another known cause.
Really? Pancreatitis, how does that connect?
Yeah, it's thought that the intense inflammation and enzymes released from the damaged pancreas can circulate and trigger that inflammatory cascade in the lungs. Even cancer or severe allergic reactions like anaphylaxis from a bee sting have been linked to ARDS.
It's kind of amazing and scary how interconnected everything is. A problem way over here can cause a disaster there.
It really underscores that interconnectedness, yeah. Inflation doesn't always stay local.
So, given these causes, are some people more likely to get ARDS than others? What are the main risk factors?
Definitely. Having sepsis or SIRS puts you at much higher risk. That makes sense, right?
Yeah, the inflammation is already raging.
Exactly. Also, just the overall severity of a person's illness. The sicker someone is from whatever cause, the higher their chance of developing ARDS seems to be.
Okay.
And one that might surprise you, receiving multiple blood transfusions has also been identified as an independent risk factor.
Huh. Blood transfusions, why would that be?
It's complex, likely related to immune reactions to components in the transfused blood, or maybe storage-related changes in the blood cells. It's an area of ongoing research, but the association seems pretty consistent, especially in already critically ill patients.
Fascinating. Okay, so someone's really sick, maybe they have sepsis, maybe they've had transfusions. How do doctors actually spot ARDS? What are the signs they look for?
Well, often the clue is in the timing. Someone is already hospitalized, already quite ill, and then they suddenly develop worsening breathing problems. Rapid onset of shortness of breath, difficulty breathing.
So it often pops up during treatment for something else.
Very often, yes. On exam, they'll look like they're in severe distress, working hard to breathe. You might hear crackles, like Velcro sounds when listening to both lungs.
Bilateral crackles?
Right. They might have a fever, depending on the underlying cause.
Okay.
And if it's really severe, you might see cyanosis, that bluish tinge to the lips or skin from low oxygen. And of course, doctors will also look for signs related to whatever triggered the ARDS in the first place. Signs of infection, trauma, pancreatitis, etc.
Sounds alarming. But I imagine other things can cause sudden breathing problems too. How do they make sure it's actually ARDS?
That's a huge challenge. Differential diagnosis is key. They have to rule out things like cardiogenic pulmonary edema, that's fluid in the lungs due to heart failure.
Right, the distinction we made earlier.
Exactly. Also, just simple fluid overload, maybe from IV fluids. Widespread infectious pneumonia can look similar sometimes. And even bleeding into the lungs, diffuse alveolar hemorrhage.
So what tests help sort this out?
Blood tests are vital. A basic CBC and chemistry panel might show clues about the underlying cause, like signs of infection or organ stress. But arterial blood gases, ABGs, are absolutely crucial. They directly measure oxygen and CO2 levels in arterial blood.
And give you that PO2-FeO2 ratio.
Precisely. Seeing that ratio drop is a key indicator of ARDS and helps gauge severity. Interestingly, the CO2 level might initially be low because the patient is hyperventilating, breathing really fast.
Trying to compensate.
Right. But later on, as the lungs get more damaged and tired, the CO2 can actually start to climb, which is a bad sign.
Okay. What else? Can they test fluid from the lungs?
Sometimes, yes. If they can get a sample of fluid from the airways, maybe via bronchoscopy, they can analyze it. Comparing the protein level in that fluid to the protein level in the blood can be helpful.
How so?
In ARDS, because those blood vessels are so leaky, the fluid in the alveoli is typically very protein-rich. So the ratio of airway fluid protein to blood protein is high, usually over 0.7. In heart failure fluid, it's typically low protein.
Ah, neat trick.
It can help differentiate. They might also run coagulation tests to look for clotting problems like DIC or signs suggesting bleeding.
And imaging. You mentioned chest x-rays earlier.
Yes, chest x-rays are fundamental. You typically see those diffuse, bilateral, hazy infiltrates like white shadows spread throughout both lung fields.
Does it show up right away?
Not always.
Yeah.
Sometimes the x-ray changes can lag behind the clinical symptoms by, say, 12 to 24 hours.
Okay.
While sometimes it can be tricky to tell ARDS from heart failure on x-ray alone, in ARDS, the heart size is usually normal, and the pulmonary blood vessels don't look engorged like they often do in heart failure. An echocardiogram, an ultrasound of the heart, is often done too to directly assess heart function and rule out a primary cardiac cause.
Makes sense. Any more invasive tests?
Occasionally, if there's still uncertainty, especially about ruling out heart failure, they might place a pulmonary artery catheter.
That sounds serious.
It's more invasive. It's a thin tube threaded through the veins, into the heart, and out into the pulmonary artery. It lets them directly measure pressures inside the heart and lung circulation. Specifically, the pulmonary artery occlusion pressure, or wedge pressure.
And what does that tell them?
In ARDS, by definition, that pressure should be normal or low, usually 18 millimilli Hg or less. If it's high, it points towards heart failure being the main driver of the fluid buildup.
Okay, so it's really a combination platter. The story, the exam, the blood gases, the imaging, sometimes these extra tests.
Exactly. Putting all those pieces together leads to the diagnosis.
We've talked function and diagnosis. What about the structure? What does ARDS actually look like if you could, well, examine the lung tissue itself?
Pathologically, you mean? Grossly, meaning with the naked eye, the lungs often look dark red or purplish. They feel heavy and boggy, and they leak fluid when cut.
Grim picture. And under the microscope.
In the early exudative phase, you see all the things we talked about functionally. The capillaries are congested with blood. The interstitial tissue and the alveoli are filled with that protein-rich edema fluid. Plus lots of inflammatory cells like neutrophils. You see damage to the alveolar lining cells, both type I and type 2. You see those characteristic hyaline membranes coating the alveolar walls. You might see tiny microthrombi, those small clots in the capillaries, and large areas of collapsed alveoli, the atelectasis.
So the microscopic view perfectly matches the functional problems we discussed.
It really does. And then later, in the proliferative or organizing phase, if the patient survives, the picture changes.
How so?
You start to see repair efforts. Increased numbers of type 2 alveolar cells trying to reline the damaged surfaces. More inflammatory cells like macrophages and lymphocytes involved in cleanup and organization. Those hyaline membranes start to get incorporated into the alveolar walls or broken down. And crucially, you start to see the beginnings of fibrosis, fibroblasts laying down collagen, scar tissue.
The start of that long-term scarring.
Exactly. The microscopic findings really tell the story of the injury and the body's sometimes maladaptive response.
Okay, so given all this severe damage, how on earth do doctors manage ARDS? Is there, like, a magic bullet cure?
Oh, I wish. No, unfortunately, there's no specific cure for ARDS itself. Treatment is really focused on two main things: supporting the patient's vital functions, especially breathing, and trying to treat the underlying condition that triggered the ARDS.
Right. Attack the cause, support the body.
Precisely. So oxygen therapy is fundamental. Giving enough supplemental oxygen to keep the oxygen levels in the blood, the PaO2, above a certain target, say 60 to 80 millimole Hg, while trying to avoid oxygen toxicity from using too high concentrations for too long.
Tricky balance. And what if just giving oxygen isn't enough?
Then mechanical ventilation is usually necessary, using a ventilator, a breathing machine, to provide positive pressure ventilation.
Who needs that?
Patients with severe hypoxemia that doesn't improve enough with oxygen, those who need very high oxygen levels for extended periods, or those who are just becoming too fatigued from the work of breathing.
But I've heard ventilators can cause their own problems in ARDS. Ventilator-induced lung injury or villi.
That is a critical point.
Yeah.
Yes, ventilators save lives, but they can worsen lung injury if not used carefully. Things like overstretching the fragile air sacs with too much volume or pressure.
Volley trauma or barotrauma.
Right. Or repeatedly opening and closing collapsed air sacs, causing shear stress. That's atellect trauma. These can perpetuate the inflammation.
So how do doctors avoid that?
That's where lung protective ventilation strategies come in. These are now standard of care.
What do they involve?
Key principles are using low tidal volumes, meaning smaller breaths delivered by the machine, typically around 6 millibelt per kilogram of ideal body weight.
Smaller breaths. Seems counterintuitive if you need oxygen.
It does, but large studies, particularly one famous ARDSnet trial, show that this significantly improves survival compared to older strategies using larger volumes. The idea is to avoid overstretching the remaining healthy lung units.
Okay, low volumes. What else?
Using adequate PEEP, positive end expiratory pressure, that's pressure maintained in the airways at the end of exhalation. It helps keep the air sacs open, preventing that repeated collapse and reopening. Moderate to high levels of PEEP are often used in ARDS. And sometimes doctors might tolerate slightly higher levels of carbon dioxide in the blood than normal. That's called permissive hypercapnia. Allowing the CO2 to rise a bit might be less harmful than trying to force it down with aggressive ventilation that could injure the lungs.
So it's about finding the least harmful way to support breathing.
Exactly. Minimizing villi is a huge goal. They might also sometimes use recruitment maneuvers, temporarily higher pressures to try and pop open collapsed lung areas, but these need to be done very carefully as they can affect blood pressure.
Right. And it's not just about the lungs, is it? You mentioned multi-organ failure earlier.
Absolutely. Supportive care extends to everything. Managing the cardiovascular system, supporting blood pressure, monitoring kidney function, preventing infections, ensuring nutrition. It's total body critical care. ARDS patients are incredibly fragile.
What about the nursing care? It sounds incredibly intensive.
Oh, it's crucial. Constant monitoring temperature, heart rate, blood pressure. Frequent repositioning of a patient, if possible, even prone positioning lying on the stomach, which can sometimes improve oxygenation.
Right, I've heard about proning.
Yeah. Meticulous oral care to prevent ventilator-associated ammonia. Regular suctioning of the breathing tube to clear secretions. Careful management of the tube's cuff pressure to avoid damaging the trachea. Managing sedation and pain relief. It's incredibly demanding, skilled work.
And fluids. You mentioned leaky vessels earlier.
Yeah.
How do they manage fluids?
Another tough balancing act. Too little fluid, and blood pressure or kidney function might suffer. Too much fluid, and it can worsen the pulmonary edema, the fluid in the lungs. So it's often a strategy of careful, conservative fluid management, aiming for an even or slightly negative fluid balance once shock is resolved.
And nutrition. How do you feed someone who's so sick, maybe on a ventilator?
Nutrition is important for healing, but tricky. Risk of aspiration is high. Usually, enteral feeding using a feeding tube into the stomach or small intestine is preferred if the gut is working. Starting it early is generally recommended.
So much to juggle. What about specific medications for ARDS? Anything targeted?
Still no magic bullet, sadly. Antibiotics are crucial if infection is the trigger or a complication. Vasoactive drugs like norepinephrine might be needed to support blood pressure, sedatives and analgesics for ventilator comfort.
What about steroids? Corticosteroids, they reduce inflammation, right?
That's the big debate. Their role in ARDS has been studied for decades with conflicting results. Some evidence suggests they might be beneficial if started early in moderate to severe ARDS, or perhaps later to help organize inflammation. But other studies show no benefit or even harm. It's not routine practice everywhere, and timing seems crucial. Definitely controversial.
Okay. Any other drugs? Diuretics.
Diuretics like furosemide might be used cautiously to help remove excess fluid, especially if fluid overload is contributing. But again, you risk dehydration or hurting the kidneys, so it's done carefully, monitoring fluid balance and kidney function closely.
So treatment is overwhelmingly supportive care, lung protective ventilation, and treating the underlying cause.
That's the essence of it, yes.
With all this going on, what kind of monitoring do these patients need, day to day, hour to hour?
It's continuous and comprehensive. Frequent arterial blood gas checks, continuous pulse oximetry for oxygen saturation, maybe end-tidal CO2 monitoring, daily or frequent chest x-rays, continuous ECG and blood pressure monitoring, temperature checks, strict intake and output measurements for fluid balance, regular blood tests, CBC, chemistries, coagulation profiles, maybe lactate levels, blood cultures if infection is suspected, and close monitoring for signs of dysfunction in other organs, kidneys, liver, gut, brain.
Wow, basically monitoring every system constantly.
Pretty much. It requires a high level of vigilance in an ICU setting.
Is there anything that can be done to prevent ARDS in the first place, especially for high-risk patients?
Prevention is tough because it often arises from another severe illness. But the main strategies revolve around prompt and aggressive treatment of those underlying conditions: sepsis, pneumonia, trauma. Early recognition and management of shock to ensure good tissue perfusion is key.
Okay.
For patients at risk of aspiration, like those with swallowing problems or altered consciousness, measures to protect the airway are important, elevating the head of the bed, careful feeding tube management. And as we mentioned, maybe being a bit more conservative with blood transfusions in patients who are already inflamed or severely ill might play a role.
So it's mostly about optimizing care for the primary problem to stop it escalating to ARDS.
That's a good way to summarize it.
We've touched on complications like VISLE and organ failure. Are there other major ones to worry about?
Yes. Multiple organ dysfunction syndrome, MODS, is a major cause of death kidney failure, requiring dialysis, liver problems, gut issues. DIC are common components. Ventilator-associated pneumonia, VAP, is a big one, a secondary lung infection developing after being on the ventilator, which can be hard to distinguish from worsening ARDS itself.
That sounds like a nightmare to diagnose and treat.
It really is. Oxygen toxicity, as we mentioned, is a theoretical risk with prolonged high FiO2, though its distinct contribution is often hard to pin down clinically. And ventilator complications like barotrauma causing pneumothorax, collapsed lung, can still happen, though less common with protective strategies.
A minefield of potential problems. Which brings us, unfortunately, to the prognosis. What are the chances? What does the future look like for someone diagnosed with ARDS?
Yeah, this is the tough part. Despite all the advances in critical care and ventilation, mortality for ARDS in humans remains stubbornly high. Generally cited figures are still in the range of, say, 40 to 60% mortality. Still, that's incredibly high. It is. It really underscores the severity.
Right.
And just for context, in veterinary medicine, for dogs and cats that develop ARDS, the prognosis is often considered even worse, sadly approaching 100% mortality in many reports.
Wow. Those are just devastating numbers. It really hammers home how critical and dangerous this syndrome is.
It truly is one of the most challenging conditions faced in critical care.
Well, as we wrap up this deep dive, let's just quickly pull together the key takeaways. ARDS, Acute Respiratory Distress Syndrome. It's a severe, life-threatening lung condition.
Triggered by massive inflammation, not directly by the heart.
Right, leading to leaky blood vessels, fluid-filled, collapsed air sacs, and profound difficulty getting oxygen into the blood.
It has many different triggers, both lung-related and systemic problems like sepsis.
It's tough to diagnose, needing careful differentiation from other causes of respiratory failure.
And the treatment relies heavily on supportive care, especially lung-protective mechanical ventilation, and addressing that underlying cause. There's no magic bullet cure.
And it comes with a high risk of serious complications, including multi-organ failure and, as we just heard, tragically high mortality rates.
And it's important to remember, as we've discussed, it's not just one disease. It's really a complex syndrome, a pattern of injury with widespread effects throughout the body.
That complexity makes it so hard to manage.
Absolutely.
It really makes you pause and think how the body's own defenses, this inflammation meant to protect us, can spiral so completely out of control and cause such devastating harm.
It highlights that incredibly fine line, that delicate balance within our biological systems.
It really does. What does this whole picture tell us about the importance of understanding these inflammatory pathways, not just for ARDS, but maybe for other critical illnesses too? Perhaps it leaves you wondering about other conditions driven by systemic inflammation and how our approaches to them might evolve as we learn more. Something to think about.